Another area of myelodysplastic syndrome that we explored in today's session looked at people whose disease is quote-unquote higher risk, meaning that they're more likely to develop a complication from low blood counts or from disease progression within the coming 1 to 2 years. And how do we view treatment approach for those patients? What updates have there been in the field? I don't know what your biggest takeaways were from today's session.
Yeah, I thought that today's session was really engaging, where we've heard from speakers who spoke about, what are responses with current available therapies in higher risk MDS, where are the pitfalls and where can we make some improvements. And in particular, we started thinking about and looking at what are some therapies that are currently under investigation that look to be promising and how they might change the MDS field if the more mature studies are able to show a positive benefit. So some of the examples, just to speak to some of the sessions that we heard about today, are looking at distinct subsets of patients who might benefit from regimens including standard azacitidine decitabine versus those that might need something a little bit more, azacitidine plus venetoclax, which is an ongoing phase 3 study which has not read out yet. But we have heard from suggestions from our speakers today about maybe some of the molecular mutations or genetic subsets that might look to benefit more so than other patients, to give us an idea for who we might consider for certain therapies to try to optimize responses. One of the challenges in MDS is we want to slow down progression to acute myeloid leukemia. We also want to improve symptoms, reduce transfusion burden, and try to improve the overall quality of life. It's a lot of asks, and so the question is, which drug can do that? Are there going to be a handful? And in today's session, we're looking at different subsets. We're looking at existing therapies. We looked at venetoclax, which is a drug approved in acute myeloid leukemia space that is still under investigation in MDS, and thought about could we do better and really identify the patients that would do the best. We also get a chance to hear from transplanters as well in our session that will discuss some of the very difficult cases, include those that feature mutations such as P53, a commonly mutated mutation in all cancers, less so in MDS and acute myeloid leukemia, but heavily enriched in patients that are older and those that have been treated for other types of malignancies. So in this growing population of patients that might have more stubborn disease compared to the average MDS, we're going to hear input from our transplanters on what can we do next and what can we do better. We ended our session today with a panel that included leukemia and transplant docs that discussed some questions that we face in the clinic, including what treatments should we give our patients that have higher risk myelodysplastic syndrome or features that look like secondary acute leukemia, what type of treatments are required before going to transplant, if any. And we also hear from our transplanters on what do they want to see in order to try to transplant their patients to increase outcome and benefit, reduce failures from happening, and unnecessary toxicity. So we'll hear some input because these are some real life questions that we face in the clinic. When do we go to transplant? How do we best get a patient there? What therapies look to be the most encouraging, and what are some alternative strategies to improve outcomes?
Yeah, I think a big takeaway for me for high-risk disease is that it really requires a personalized touch, and that as a patient, there are many options still, but being able to consider all those options, including transplant when you have this diagnosis, potentially getting multiple inputs. I myself don't do transplant, but I work very closely with our transplant colleagues. And so for me, it was interesting to hear this discussion between the interplay of shared care, where after a patient's diagnosis, there's a consideration around pre-transplant therapy as well as around transplant therapy. And in the end, it really matters that both sides know the patient and that they tailor the treatment approach to what's best for that patient. And so I think we have made a lot of gains in providing therapies now that are available to patients even as you get older. We're able to provide therapy to a broader group of patients, or people who have different mutations. We're looking at them as a specific subset so that we can tailor treatment not only at the beginning, but also with transplant and even potentially after transplant to try to give that person the best outcome. And so I think, it is impressive how the field has kind of really worked to be more inclusive of who's eligible for our treatments.
Yeah, and I think that, just to conclude, these final thoughts, I think that we got left with a lot of optimism for understanding where the gaps are. Everyone is in agreement. We need to optimize therapies and outcomes. And it was really helpful for us to get a sense of what our colleagues think of what area or which particular detail that they need to expand upon to really make a difference and start looking at investigation. So whether or not it's nitpicking at mutations to figure out how can we try to enrich responses in specific groups, to really, improving toxicities from certain therapies, or making shared decisions together for when a patient should move to treatment versus transplant or both. It was really great to hear from everybody, their input, because at the end of the day, our ask is the same, is how can we improve outcomes for our patients? And getting everyone's input has been really valuable.